Okay, Kusum, can we start the webinar?
Yes, Dr. Shri, we are live.
Yeah. Okay. Good evening and namaste. I welcome all the speakers, the panelists, and the participants. Kusum, can I have my presentation shared on the screen?
Yes, Dr. Shri, it's just coming on in a few seconds.
Okay. So the format is that I'll quickly introduce the National TB Control Program and why we would like to orient the for-profit organization. And then I will hand over the Kusum. Okay. Okay. Yeah. So the India has progressed well in the health sector in the last couple of years. But however, we realize that private sector in health has gained significance and it has been a preferred partner to realize the public health goals. And also the National TB Control Elimination Program has been trying to engage the private sector in its effort to end tuberculosis. Next slide, please. Next slide. So this ending tuberculosis will not be possible. There seems to be a problem, Kusum, in the presentation. I'll just go on. So this ending TB will not be possible without the engagement of the private sector. And as we know, in India, we have a diverse private sector, which includes from informal solo clinician to highly specialized hospitals. So Government of India has been trying to involve this private sector through public-private partnership schemes. In fact, it started in 1999 and there has been a couple of revisions. And there is also a very high political commitment and the Prime Minister's office has committed to end TB in 2025. Next slide, please. Next slide. There seems to be a lag. Yeah, next slide, please. So there has been a couple of challenges in involving the private sector. There is a high out-of-pocket expenditure and private sector does not really have a mechanism to ensure the treatment adherence. Next slide, please. And when we look at the public sector, there is a well-established laboratory. There is a hierarchy right from National Reference Laboratory to the microscopic center at the periphery. And fixed dose combination drugs have been made available across the country. It includes the patients who reach private sector for accessing care. Next slide, please. So what have been the policy initiatives to involve the private providers? There has been a Gazette notification issued in March 2018, which mandates all the private sector practitioners to notify TB cases to the national database. And also there has been an implementation of Schedule H1 drug, which to improve the notification from the chemists as well. Recently, in 2019, there's been a guidance document on partnership on which Professor Venkat will be dealing with this partnership guidelines and principles. Next slide, please. So coming to the TBPPM Learning with Network, where me and Kusuma are working, this is with an intention of bringing the different stakeholders together and empower the private organization as India PPM stakeholders. We need to strengthen this PPM ecosystem, and this is one of the effort from the learning network to bring the different stakeholders together. Today, we thought the private for-profit organization have a huge potential of contributing to the TB elimination programs. And that's why we thought we'll have an inventory of organization and see how we could collaborate with each other. Next slide, please. Next slide. We have also been developing the directory of non-profit organizations as well, and also the IT agencies who are working in the TB control program. And we are facilitating the peer group interactions. And from here, we'll introduce the PPSA guidelines and what has been the models. And we'll see who will be interested, and we'll like to interact with them and take them through the models in future. Next slide, please. So I hand it over to Professor Venkat. Professor Venkat, over to you.
Thank you, Sri. It's a pleasure to be always there in this learning network for whatever bit of pieces of information that I can share and contribute to the understanding of private sector engagement in this forum. For some of us who are familiar to the private sector engagement, this particular information that I am giving is going to be somewhat ad nauseum kind of an information. But some of you who are not familiar to the private sector engagement strategies, this could be just a beginning to understand. Usually when we look at the private sector engagement, we try to look for what is the scope for the private sector to be on board with the government in terms of partnership or engagement opportunities. One is in terms of bringing in health infrastructure, in terms of building hospitals or any kind of, this is a classic case of what we call it as public-private partnership. Then there is a second kind of opportunity wherein the service delivery, both clinical and non-clinical service delivery, and this is mostly called as contracting or management contract or O&M contract. Then you have a third version, which is in terms of purchasing through or any kind of financing, either through insurance or strategic purchasing, etc. Then there are a large number of miscellaneous opportunities that happens between the public sector and the private sector, and that is in the form of human resource supply, capacity building, regulatory collaboration, etc. These are the broad umbrella of opportunities for the private sector collaboration. Now, the second most important question that we need to ask is, who is the private sector? I think in Indian context, the private sector is not a unitary unit in terms of only the corporate hospitals. A very predominant proportion of private sector in India are owner-operated enterprises, whether they are nursing homes or polyclinics or just a daycare kind of a facility. Tertiary care or super specialty hospitals constitute just about 5 to 7% of the private sector in India. So we are looking at in a predominantly individual practitioner setup. How do the TB care patients or TB services could be optimized by mobilizing these individual practitioners? Therefore, that's a kind of a foundational issue that we need to also look at. Dr. Vijayashree already mentioned about the journey of RNTCP to NTEP now. Starting from 2000 onwards till 2019, there has been several attempts at roping in the private sector by giving all kinds of packages, whether they are grant-in-aid kind of packages or opportunities to collaborate, or what we are looking at from 2013 onwards is a performance-based kind of a contracting, wherein you introduce an intermediary agency, because governments are always a suspect in terms of its ability to engage individual practitioners. So you bring in an intermediary agency who act as a nodal or a mobilizer of the private, or if you were to say in a modern terminology, an aggregator of the private provider, so that there is a greater ability of the intermediary agency to reach out to the private sector and mobilize them at a greater number compared to the government itself. This started within 2013 when we had universal access to TB care under the BMGF grant. This was in 3 places, rural Patna and Mehsana and Mumbai. But later on, it got expanded under the Global Fund. All of us would know about the JEET project. And in 2019, under the National Technical Working Group for the Private Sector Engagement, wherein a large number of you were there as part of this entire effort, there is an element of introduction of performance-based contracting now. I'm not using the word output-based contracting because that is a technical term, whereas I'm using the word performance-based contracting. What are the features or uniqueness about these performance-based contracting that the guidance document of 2019 spoke about? Number one is that the terminology itself, the guidance instead of guidelines, is an interesting terminology because it allows the states to really innovate, improvise, and adapt to the local requirements rather than being dictated by the CTD from the center. Second, a composite index of performance metrics was developed, and the payments were based on the achievement of these performance metrics. I think the reason today we are here to debate about the role of commercial enterprises in commercial private sector in this TB control program is often private sector, especially the commercial sector, tend to focus on the results rather than on the processes or the inputs. And therefore, this is one of those attractive features that was also part of this, the new guidance document. The third interesting element here was the need assessment-based private sector engagement, which meant that the local governments need not, or local administration, private public sector administration, whether it is district authority or state level people, need not blindly think about private sector engagement because there is also in-house capacity. Besides the in-house capacity, if there is a need for the private sector engagement, which is that area where the private sector needs to be brought on board. That flexibility was also given. The third element, the most important element, which is also changed the overall narrative of this TB elimination program, is the bundling of services. And that's where the role of commercial enterprises or commercial private sector comes into play. I'll talk about that after a minute or so. Use of interface agency was not something new. It is just an extension of what was already done in the UATBC and the JEET project. Market discovered tariff structure was another added feature to this. IT enabled contract management, two-stage bid process, that is what we call it in generally QCBS, or quality and commercial cost-based screening of the private bids, QCBS as popularly called as. This is an added dimension and something of an innovation, so to say. And the last part is that in terms of institutional capacity building, we were focusing on bringing in a national technical support unit as well as state level technical support units to help in their contract design and its management. Now, in the last 2 years of its journey of the new guidance document, there have been several teething problems. It's not something that I will always say this particular statement that the private sector engagement in service delivery is always a work in progress. All right, it needs to constantly evolve because the service delivery features tend to change. Unlike infrastructure projects where it's a 25-year-old contract, in many of the service delivery contracts, the situation, the contextuality, the elements of the local play, etc., are extremely dynamic. And the nature of the service delivery contracts also need to be evolving. Now, finally, just about a minute, why this debate on the private commercial sector, especially in the TB control program? Number one is that the bundling of services changed the overall approach. When this was a discussion that I had with Dr. Vijayashree a couple of weeks ago. In fact, during the discussion in the National Technical Working Group, we allowed a great deal of private sector enterprises to come in to bid into the PPSA mode, that is, as an interface agency. The idea is that the private sector brings in a great deal of its own technical and managerial capacity, whether it is in the diagnostics space, whether it is in samples transport space, whether it is in terms of IT innovation, whether it is in terms of managerial capacity. There is a great deal of strength that the private commercial sector has. Ideally speaking, we would have loved to have a consortia approach towards intermediary agency, wherein private sector, commercial sector, along with the NGOs, come together as a consortia and leverage each other's capacities in terms of whose strength is where. For example, community mobilization, public health action, counseling, advocacy, all these NGOs have a great deal of, non-profit organizations have a great deal of strength. The private sector may not want to venture into these commercial enterprises. So they might like to really facility-based kind of service. So it's a kind of a consortia which works to the best of this project. And private sector also has a great deal of agility and flexibility, and that's an added advantage. And lastly, and most importantly, till date, we are not able to get a large number of interface agencies to bid for or to compete for NTEP, private sector engagement interface agency kind of opportunity. We are looking at the private, commercial private sector agencies to also come on board and be part of this journey towards the national TB elimination. That's the reason why we thought it would be important to have a dialogue in this forum. Thank you so much. Sorry.
Thank you, Professor Venkat. Thanks for setting the tone. I would move to Ms. Manisha Mishra, who is from ONMG. Manisha, over to you. Yeah, you're on mute, Manisha. Manisha, we can't hear you. No, we can't hear you. Yeah, go on.
Hi.
Yeah. Manisha,
Thank you.
Your voice is not audible. Maybe you can check your audio settings.
Kusum, pleasure to be here. Okay.
Manisha, there needs to be a bandwidth issue. If you can close the video, perhaps the sound quality may improve.
Let me just. Am I audible now?
Yes, yes, Manisha, please go on.
Can you now?
Manisha, we are not able to hear you.
Yeah.
Yeah, maybe meanwhile you fix that, Manisha. We'll reach out to Dr. Nilesh. Dr. Nilesh, are you there?
Yes, I'm very much there.
Yeah, Dr. Nilesh, over to you. Meanwhile, Ms. Manisha fixes the audio settings.
Sure. So should I start? Should I go ahead?
Yes, Dr. Nilesh. Yeah.
So I'm going to share my few experiences of dealing with public-private partnership, some partnership which concluded and we executed, and some we were just the bidder and we lost. So the idea is to put some suggestions as well as a private player for authorities to take it positively. I also want to respond to one of the message which has just come. PPP is very bad. I just want to respond to that also. And as a private player, I want to tell you all in one line, if I were to give a message to you, all PPPs are not bad. In fact, I want to say there are some PPPs who are so good that they change your internal working in positive direction. And I want to share that experience of my dealing with specifically one PPP which we are handling is from NACO. So I'll take a minute or two to narrate what NACO project was. NACO project was about us setting up collection facility at 525 ART centers, collecting blood samples on a agreed frequency, bringing it to central lab and delivering reports back within 24 hours of time. So logistics time was 48 hours and testing time was 24 hours. These 525 locations were across India, even at a rare northeast kind of location, and the lab was in Bombay. It was a very challenging task, but still I would say it got executed successfully with more than 99% of compliance. In fact, we had no penalties at all so far. Even in challenging period where few flights getting cancelled or even COVID time, I think we have been able to manage. The whole success of this partnership does not go to Metropolis alone. I think it is overall the vision of tender. And I want to go ahead and narrate some of the good things which this tender had done. So let me start with some good point which tender build itself had. So if you read NACO tender, it is very comprehensive, very clear deliverables, and the quality parameters, testing parameters, what test technology you will use, everything is very well narrated. Very important part, they have the well-defined bidders criteria. These bidders criteria were such that only good quality, experienced bidder who can actually manage this kind of complex project can only participate. I've seen in many of the PPPs, when bidder criteria are not well defined, some smaller labs or diagnostic center, they participate. And frankly, they actually create a lot of commercial war, which was not necessary. And I've seen some failing PPPs as well. But here, the bidder criteria are well defined. The clarity on expectation was very well laid. Tests, see, they were very quality oriented, and hence test technology, everything was fixed. You cannot bid for this until you adopt the same tests and technology. So I felt this tender definitely looks forward to a good quality work. So that's why we were very encouraged to participate. The service criteria were very tough, but still reasonable. Something with some hard work you can meet. And when I met in 45 days setting up so many centers, it gave me so much of confidence to do something bigger and better for other projects. Even from our regular work, also it gave us a lot of confidence and learning. So service criteria were well laid. The measurement criteria were very well laid. That was also very important. How do you measure success of the project? What we are doing? How do you evaluate whether we did good job, bad job, ugly job? So the quantifiable criteria were well laid. There were reasonable penalties. See, penalties, another thing which in many of the tender, some of the private player, at least I would say for ourselves, we do not bid because penalties and expectations are so unreasonable that you may land up with only penalties and not deliver, and you may get blacklisted. So hence, with that fear, many of the tenders actually do not attract private players. The most important part I want to mention that the tender document had evaluation criteria, and the winner would be given weightage only 30% on commercial side. 70% was on your experience and quality and your performance on that, even including How will you execute the project? That document we were to submit, the plan we were to submit, and plan was also reviewed. So this was fantastic thing. What you have done so far, what have been your quality credentials, what is your plan? These were given 70% weightage, and only 30% weightage was given on commercial portion. All this put together, I think the tender was very attractive. We went aggressive. We quoted an aggressive rate. And at times I was afraid whether we'll be able to, if not profit, whether we'll be able to meet our numbers and do a good job. I think it was fantastic experience. It made us also learn how to manage in a smaller cost with similar quality and service standards. One more thing of the tender. Now I'm coming to after execution of tender. The tender document does say that the NACO team and their neutral team will come and audit. There were two things which also helped with the quality of the quality outcome. One, their periodic audits. They took pain to not only audit our lab multiple times, but they took also pain to go to all the ART centers. How good service are we giving? They cited something as small as your needle cutter, where the needles are getting collected, that box is overfull and the number of patients are more. So you have to put a bigger box. Right from there, or even emotions of the punctuality of our phlebotomies, everything they captured on their audit. This was very useful. Because of their findings, many a times our learning and development, our training plan improved substantially. So I felt this PPP was true partnership. Public people really came as a partner to private people, and both together created a fantastic outcome. And hence we got extension, and we really feel proud for being part of it. However, as I said, anything and everything you do, there is some area of improvement. I did say that all PPPs are not bad, and most of the PPP have some good points, but yes, there are some areas of improvement. So a couple of things which I observed also in NACO tender, the storage guidelines were too tough, which were not in line with what was actually required, which needed some correction. But once the tender is out, you cannot make correction, and we have to live with it till the tender is complete. So that is one thing which we observed. Second, the billing requirement, where each bill has to have a supporting. And we have, for that supporting, we have to go and take signature from 525 people, 525 centers, and at times those people are not available. Those taking signature and submission of bill itself was a big challenge. So these are a couple of areas of improvement which we felt, and I'm sure in the next tender they will do this improvement. They were agreeable. But overall, I would say it's a tender which changed Metropolis, the company I represent. We changed companies, many of our processes, and it was a good scenario for us. So the big lesson I learned about pre-analytical part, where my pre-analytical area completely improved because of this. Let me come to another tender which we did in MCGM. Now, one of the things, MCGM, Maharashtra tender, Bihar tender, Punjab tender, many of these tender which we have made, MCGM we have won, we are executed also, is about bundling of the test, where they give set of a test and they say you have to quote one price per patient you quote, and all these tests becomes basket, where whether somebody says 5 tests or 15 tests, there will be one price. Now this makes labs very difficult to execute, extremely difficult for us to understand how to quote. So this is one place where I would suggest the authorities to consider not bundling, at least test side. I know in TB we are talking about bundling of many other things. I'm not disputing there, but bundling of many tests and giving one price is very complicated. It's not very easy unless we have some more information given along. The second big message which I want to give is about way you tender. So in interest of time, I'm cutting some point. But in interest of getting a good quality, please do not follow L1 criteria. My firm suggestion is that L1 actually kills interest of many of the private players. I would propose a good empanelment which is connected to you defining tests, technology, service norms, turnaround time, quality, audit, reviews, everything well defined. If these criteria you meet, and even experience criteria and your network and all those criteria, once you meet, if these criteria you meet, then you are allowed to get empaneled. So such empaneled panelment would ensure that, you know, the quality is not compromised and interest is at large. And the last suggestion I want to make is that once empanelment happens, or maybe in case you are going for tender and tendering happens, the authority should do rigorous audits at frequent interval that keeps all the winners or bidders on toes. This is extremely critical, and I've seen some of the PPPs, they are not doing it. Like, you know, CGHS, for example, you get empaneled, but, you know, nobody comes and does the audit. So there are people who give so low rate, beyond CGHS rate. I don't know how they afford, because it is lower than even cost of the material. I don't know how they afford. Now, this brings big quality impairment, and which is not something which any one of us want. So these are my few points and sharing which I want to do, and happy to answer any questions which may come up later. Thank you so much.
Dr. Neeraj, thank you so much for these insights. Maybe we can take the questions later in the session. Yeah, thank you so much. Ms. Manisha, if you are ready, I will just hand it over to you. Over to you, Manisha.
Sure. Thank you, Dr. Yellappa. Am I audible now?
You're audible, Manisha. Please go on.
Yeah. Thank you so much, everyone. I really enjoyed listening to Dr. Shah's views and inputs. Most of mine are also similar, and I'll come to them as well shortly. Very quickly, I am Manisha. I lead the strategic initiatives at Tata 1mg, and we have been very fortunate to be participating on a PPSA program along with Clinton and my colleague Arnab is also there on the call. It's been a great learning experience for all of us, given, as it was rightly mentioned, for us, when we come from a commercial mindset, for us, end objectives and outcomes are what is most important. So very quickly, I'll share what our journey so far has been, what have been some of our learnings in terms of enablers and barriers, and some suggestions to prospective commercial entities listening in here today, to encourage them to participate more so in such programs. So Tata 1mg, as many of you may know, provides access to medicines, diagnostics, and connects with doctors for pan-India. And to do so, what we generally rely upon is the technology. For us, technology has been the backbone for almost all of the things that we do. Using the technology and the supply chain that we've built over the last 5 years, we were fortunate enough to work with the CHAI on a TB project as a PPSA model. Under this, our roles and responsibilities were well defined from the very beginning, and this is one of the suggestions that I had for all such models. That's always good that at the beginning of the tendering process or the contracting process or the onboarding process, each stakeholder should pay a lot of attention on what is the exact scope and responsibility that they are going to spearhead within the PPP model, and spend ample of time to understand the ownership, the responsibilities, and the KPI. Because as Dr. Shah also mentioned, it's actually each of the stakeholders' KPIs that sum total to the overall project success metrics. So what we do in this program is we provide access for TB medicines and access to TB diagnostic tests to patients post a doctor prescribes them the following. What we also do is place a lot of emphasis on adherence. Month on month, patients are taking these medicines and being counseled to actually consume these medicines on time. So a lot of focus is on patient centricity and better health outcomes. In this program, we're working with multiple stakeholders, including the state governments who are providing us the free of cost TB medicines. For us, the whole journey has been actually very smooth. And when we started this project and when we were in the initial contracting process, we were, to be very honest, a little apprehensive because we had not done a similar, public-private partnership model in the recent past, where large-scale medicine delivery and diagnostic test and adherence calls, etc., was involved, and also where patients' health outcomes were involved. However, for us, thankfully, it has been a very, very smooth, journey. And a couple of reasons that I can reflect upon and share with all of you are that from the very beginning, there was a lot of emphasis on setting the right processes, setting the right, KPI metrics for all stakeholders, and making sure that there was a regular quality check, monitoring, and governance meetings. While all these three may sound very cliche, all projects are supposed to have all the above, but I think it's the implementation of how these three happen, how well they are executed amongst the different stakeholders that makes a difference between success and failure of such kind of models. For us, some of the enablers, were that Tata 1mg already had a geographical coverage, and so we were able to cater to the cities that were part of the project. In fact, we can cater to more number of cities, and we're working, to get more such projects as well. Of course, there was a lot of opportunities for cross-learning and knowledge gains, given that we were working with diverse set of ecosystem partners, and each one brought their own learnings, inputs, and suggestions. One of the primary enablers was also technology. Again, from the beginning of the project, all of us who were part of the project teams and all different stakeholders were at every point of time asking ourselves that can technology automate this process? Can technology help us ensure that quality is actually delivered? And how well could we execute the same? So for us, these were some of the enablers in the whole process. I think it's been a great learning experience for us. And I personally, because I also come from a development background prior to Tata 1mg, I was working in the development sector and have also been part of several other large PPP programs. One of the suggestions that I would want to put forth to everyone listening in is, while these kind of models and programs seem to take their own time when they begin, there's a lot of things to put in place, and at times the model appears complex. However, with the right structures and foundations and processes, they are a win-win for all stakeholders. Such kind of models provide a platform, to work with other ecosystem players in a very structured manner and facilitate cross-learning. They also, open up opportunities where high volume or high scale-up can be immediately done. So if such pilots of PPP models are successful, then it's easier for other stakeholders or consortiums even to take the learnings, replicate it, make a playbook, and then lead to benefiting more number of patients across India. So I believe healthcare is one such area, where if processes are streamlined at the beginning of such programs and models, easily these could be scaled up in other cities as well. While we were on this journey, some of the barriers that we initially faced, and it would be only fair for me to also mention that along with the advantages, is some of the barriers in such kind of models and programs are that oftentimes they appear to be a very slow process to align all ecosystem players along common objective. Some of the times they could be even competing objectives, like players could have competing objectives as well. So how to define a midway? It requires a lot of patience and a lot of coordination, especially at the beginning of the program. And if that much patience and coordination goes into at the time of onboarding and kickstarting such programs and models, they definitely lead to positive outcomes. The second, barrier, or rather a suggestion or a challenge that often comes in these kind of programs are accountability management and its importance. When together a consortium or a mix of players are bidding for any PPP models, it's easy to divide the scope and the responsibility, etc. But when the project actually starts and each other's work is dependent upon each other's deliverables, then accountability management and how important it is becomes very clear. Like one of the examples that I can share with all of you is in the PPSA project, we work for the diagnostic with the government-led diagnostic centers. In the beginning, given we came from a different mindset, and our processes were more tuned to the processes of a private lab setup. When we started interacting with the government diagnostic labs, we faced a lot of issues in the TAT. The TATs were increasing. It was a recurring issue, etc., etc. However, once we went to the root cause, we were actually able to redesign the whole process of the sample collection to the report delivery, and we were able to then further, optimize the TATs. So, of course, there will be challenges and there'll be barriers, given PPP models are not easy to either deploy or, to execute. But for us at Tata 1mg, it's been a very, very, useful journey for us. It's led to a lot of learning at our end. And we've, at our end also, we've gone back to our supply chain team or the diagnostic team and given and shared a lot of learnings that, hey, this is a process that can further help us serve even our customers better. So yeah, that's in short, very brief of our journey with such models.
Thank you so much, Manisha. This has been a very insightful reflections. We can take the question. There are a couple of questions. We could take it in the later in the session. Over to you, Pitambar.
Am I audible, Dr. Vijayashree?
Yeah, you're audible, Pitambar.
My name is Pitambar Soren, and I am from Innovation Health. And our organization is serving the rural community in Bihar since 2010, and we are serving the private sector engagement since 2017. Next slide, please. I will give you some insight about the PPSA, like little bit about the what is about PPSA. The prime aim is to increase notification and ensure successful outcome. It is expected from the PPSA, and it is a kind of interface agency that is going to serve the NTP and the private providers and patients. And the primary objective is to provide patient-centric services like diagnostic linkages, like treatment linkages, and DBT, all this kind of. And another objective is to reduce the out-of-pocket expenditure of the patients, and to provide free diagnostic drugs and support services like counseling and home visits, all this to the TB patients, and to be with the patients till the end of treatment. These are the prime objective. And there are several components in the PPSA package, like provider management, like you have to identify the providers, you have to enroll them, you have to manage those providers, and you have to put all those identified patients with the diagnostic linkage, and you have to provide them drugs also, and you have to there is a mandatory testing like HIV and diabetes testing, and you have to put them patients for you have to make them diagnosis for this kind of testing. And also you have to ensure that there is you have to ensure that UDST, like drug susceptible testing, and you have to facilitate the notification, like you have to enroll them in the next, notify them in the next year also. Also you have to prepare the provider incentive also. These are the component of the PPC package, and apart from this you have to provide them the counseling service, and you have to visit them, the patients, through home visit. Next slide, please. There are some advantages for the working in the PPSA. As a PPSA, there is some advantage you will get. Obviously, earlier for the private intervention, there were donors who was giving grant or donation for the private intervention. Now this ownership is up to the NTP. NTP is having that ownership, and it's good that it is NTP is having that ownership, financial ownership. And obviously, as you are the prime interface with the private providers, and you are the sole person who is going to deal with the private providers, you are going to get their reputation. You will harvest that reputation. It's the good thing of the PPSA, and it is because of you are having a direct interface with the private providers, and the private providers are your asset, because anyhow whatever things they will share with you, they will depend on you. That's why these are your asset, and you can private providers will be your great asset in terms of anything. You can do good quality of notification, good quality of your services. And as you are the owner, nobody is going to question you that what are you doing, how are you doing. You are going to preparing your own strategy, and you will get less interference because you are the only agency who is going to deal with the private providers. And obviously you are going to earn the supportive hand in terms of like the private providers and the compounders, because without the supportive hand, you are not going to able to manage all this kind of notification, all this kind of DBT, drugs linkages, all this. You are going to have that kind of supportive hand in terms of compounders also. And obviously you have your own choice of selecting labs. Either you can select the public setting lab or the private setting lab. That have your choice there is. And obviously as you are going to do everything in the Nixa, you are going to notify the cases, you are going to put their diagnosis in the Nixa, you are going to put their documents like account details, everything. You are going to be a masters in Nixa. These are good things. And obviously, as you are quoting your own prices per patient in the PPSA, and I think that it can be either cost to cost, or you can have some kind of additional profit. So it is going to be a financial viable option for the PPSA. These are the good things of the PPSA. Next slide, please. But along with the advantages, you will have some kind of challenges also. Like there is a ownership perception, and that perception means everybody thinks that it is your responsibility. As you are getting money, as you are the only dealing with the providers, it is your responsibility. NTP official think that it is not our responsibility. That is a kind of owner perception there is in the among the NTP officers. Like the STS in the TU level, STS purely think that it is your program, your intervention, and you are the responsible person. They simply say that, and it is because that they act as the indirect interface. They are not the direct interface with the private providers and patients also. And because of this, there is some kind of frictions also. Like they say that when they simply dial some numbers of the patients, if for any reason the patient isn't able to be contacted, they simply say that it is a fake patient, and you are doing, not you, your private providers are doing all this because of the DBT, because of the money. That deficiency of trust is there. And in terms of DBT also, they simply say that if the patients belongs to our tuberculosis unit, then we'll provide all this facility, we will provide the DBT. If it is out of our tuberculosis unit and our out of district, then as we are not able to monitor that patient, we are not going to discuss the DBT for that patient. Even timely DBT is also another matter. If you are not having that proper documentation, then you are not going to ensure the DBT in time. And similarly for FDC, the patients, what patients attitude is that if once the patients get to know that I am having TB and I will be delivered the same drugs, the same prescription by the patients, then he wants that medication from at the residential tuberculosis unit. Then he wants that medication from the residential tube. But there is a provision that to get the drugs or FDC, patient need to come to the clinicians and that notifying tuberculosis, then only he will get that medication. But because the patients are unable to afford the prescription and consultation fees, they want that medication in the at the tuberculosis unit, but and this is the challenge that they are not able to get that medication at their home unit. And there is a common perception that private, as they are going to the private providers, they can afford the diagnosis, they can afford the treatment. It is a common perception. And because of all this, there is a lacuna of trust, there is a deficiency of trust, and that's why the STS, like treatment supervisor, they gets alienated to the PPS chief. They simply say that you are increasing our burden, you are increasing our work in terms of DBT, in terms of monitoring, in terms of FDC, everything. We are increasing everything. And when we send the patient to the NAT lab for the UDST, drug susceptible testing, and there is in the NAT test, they test the patient for the public and private. And obviously, public patients are given the first preference, and the private patients are given the second preference. That is another challenge. And if you are not able to provide all these facilities like diagnosis and FDC, then obviously you are going to face that backfire from the physicians and as well as from the patients also. And active physicians is another issues that minimum 40 to 50% physicians are active, rest of the physicians are not active because of the trust deficiency. And obviously recognition is another. If there are so many physicians who want to, who are saying that if we will get the DBT, then we'll obviously will not get any kind of consultation fees, but that kind of recognition we should build up. I have a few recommendations, like we need to think on the earnest money deposit, like there is in our there is 10 lakh per cluster. You have to provide that EMD, and we need to think on this, that how can we is this terms and conditions. There is also performance security. You need to pay 5% of total your annual budget of per cluster. You need to pay that performance security. Even there is also delay and performance penalty also. We need to think on this, that how can we make it better platform for the bidders or PPC agency. And we need to also modify our evaluation criteria. There is a financial criteria that if your annual turnover is more than 10 crore, you will get more mark. If it is less than 10 crore, it is less than 4 to 7 crore. Like this, there are so many evaluation criteria. We need to think on this. Similarly, we have to nurture the ownership among the NTP and the public health system. That in the basically in the TU level, there is a problem of ownership, that they think that it is not our program, it is the program of the PPSC. You need to nurture that ownership. And to obviously to nurture the trust among the private providers, we need to provide them the DBT diagnosis drugs in time. Otherwise, we are not going to get that trust. Similarly, NTPs should take that leadership in the stakeholder engagement, like the IMA, Chemistry and Lab Association. And PPC can be a partner, can be a supportive for that purpose. And as the compounder is the prime stakeholder in the private sector engagement, we need to think on that. If no doubt doctors is on board and doctor is ready to notify the cases, but if compounder is not on board, you're obviously are going to miss the cases. That's why you need to think on the compounder, that how can we involve more the compounder. We can involve them as treatment supporter. We can incentivize the compounder also. And there are so many practitioners, like specialized practitioners, they treats, but they cannot notify. We need to think on that, that some chunk of patients are being treated by the practitioner, informal practitioner. We need to think that how can we tap those. Similarly, for the report dissemination.
Pitambar, I'm sorry to interrupt. In interest of time, I request you to please wind up in a minute. Yeah. Thank you so much.
Sure.
Apologies. Yeah.
Oh, sure. We need to think on the digital scope, that how can we disseminate the digital report, so that everybody can access. Similarly, to build the trust among the NTP officials, we need to have some kind of digital files in the Nexus, so that we can upload the patient prescription, we can upload their diagnostic reports, so that in single click they can access, and it will build up their trust. Similarly, for the PPS also, if you will get the advance payment in the beginning quarter, and if the payment will be on time, it will be good for the PPS. These are my recommendation from the field experience. Thank you. Thank you all for listening.
Thank you, Pitambar. I hand over the floor to Professor Sarang for the moderation. Thank you for all the speakers. Over to you, Professor Sarang.
Thank you, Shri. Good evening, everyone, and thanks for sticking around, those who are still here among the attendees. We've got a very distinguished panel, a lot of collective experience, both professional as well as personal in the field of TB. So my job is essentially to facilitate a conversation and a dialogue, channel all the insights that the panel members already have for the attendees, and then also leave some time for questions that the attendees may have for the panelists as well as for the speakers. I know we are tight on time, we have only half an hour. So I'm going to jump straight to the panelists and sort of ask them for their initial reaction. Let me start with Dr. Neeraj. Dr. Neeraj, I hope you can hear me.
Yeah, I can hear you.
Thank you. So the reason to start with Dr. Neeraj is because he heads the National Technical Support Unit, NTSU. One of the main responsibilities of NTSU is to foster greater participation from private players towards achieving the goals of the National TB Elimination Program, NTEP. Probably NTSU is one of the prime examples of a private player itself engaging in the role of NTSU. So, Dr. Neeraj, from your vantage point, could you talk about what you expect of for-profit entities, commercial entities? How could they play a role in achieving NTP's objectives, and maybe with some examples of which services are they better poised, better positioned to deliver? Thank you.
Yeah, I think for-profit organizations and the commercial organizations can play a very important role in the private sector engagement piece. Reason being, it's high time, in public health system, somebody interfaces with them and shows how this can be done in a very professional and in a manner that can lead to profit for the organization, and also in terms of efficacy. We have several examples which we already know. Now, if I wanted to get a blood test done, I know I need to call up either Fortis or a Lal's lab or somebody, and tomorrow morning somebody's going to pick a sample. This is how effective the private sector is. And it's a pity that we have so far not capitalized it. And the new partnership guidance documents were released in 2019 provides us just the opportunity. I think one thing which is obvious when you ask for examples, definitely, we need the private players, and not only the big ticket players, even the local players in the system. And just imagine, we have a huge network of TB diagnostic labs in the TB program. It's inconceivable that these labs would not be shut. One of the labs, or we don't know how many labs are shut down today and would not be functional due to, say, electricity issue or some other local issue. I have been advocating since NTSU has come on board that each state TB officer gets into a MOU in a fee-for-service agreement with the private sector labs that anytime any of their labs shuts down, they have an already in place agreement. So there is no interruption of services. So that, end of the day, so diagnostic is one area where I see a lot of value for having them. So, and I have seen from my past experience as well, that a sample picked up from somewhere in UP lands up in Gurgaon, gets tested, gets reported within, fixed time. And what a patient really wants is that I know, when I'm getting the result and it will be delivered to me. So you already won his trust. We want that on board. Similarly, what the specimen transportation piece is one piece where we should have for-profit organizations who are doing this in a very professional manner, in which currently we have different sets of tests at different levels. Drug susceptibility testing is happening at a different level, and a basic diagnostic test or a molecular assay is happening at a more peripheral level. So now you do even if I walk into a peripheral healthcare facility and I get the best of the diagnostic which is available prescribed for that lab, for me to get an evidence-based treatment ASAP, I want this linkage to, and this is where, in case I don't get that result, supposing transportation takes time, or, I don't get the result fast from the tier 2 labs fast, these are the patients we're losing out of the, from the program. And then a lot of effort is being spent in tracing them back and bringing them back, counseling them. So you do it efficiently and half of your work speaks for yourself. So you get these players on board who are into logistics and who have professional experience, who have been transporting this. So we, TV program has been there for last, how many years, but, and we really don't know, there are so many areas where, as a program, we have not ventured. Why not capitalize on what is there on already existing and, just build on their network. Apart from this, a third example, what I would like to suggest and advocate for, maybe it's too revolutionary to think about, is that a patient provider support agency being run by a for-profit organization and demonstrating, because PPSA works in very close manner with the DTC. And I hope that there is some lateral learning, that how efficiency, and this efficiency is infectious. You see somebody working with you who is infectious and not infectious, efficient. So, and there is a lot of cross learning. So yeah, some thoughts. I think I have a short time allocated to me.
No, this is very, very useful start. You've laid out the broad contours. Just for the benefit of audience, let me recapture what you said. What I took away from your comment is private sector has certain skills, certain capabilities. They have been utilizing those capabilities to deliver certain services to patients in the sort of outside world, outside of the TB program. And the same patients have been availing of those services from those same private providers outside of the TB world. So which means market is working in some parts. Now, is it possible that the same connection between the private players and the same patients happens under the aegis of the program? So that's exactly. Those same values can be delivered. And the other thing that you mentioned specific services, lab services, sample transportation and collection, where these capabilities exist. Maybe a wish list was this private provider, patient provider support agency, which is, I think, more complex than providing piecemeal services. I'm going to take two cues from what you said. And one, I think you mentioned in passing that the customers or the patients will benefit because they may not have to run from pillar to post. The private provider will create the seamless service. I'm going to go to Ria in a while. I just want to warm her up because she sort of represents a very important stakeholder from the patient perspective on what she feels. But you also mentioned this wish list of PPSA. So I'm going to go to first Shibu. who has worked very closely, first with the UATBC or PPI programs, then part of JEET. Shibu, you've understood PPSA, PPI, this interface agency operation very closely. But we know that a lot of these have been run by not-for-profits. I mean, be it PATH, be it CHAI, be it FIND, whatever, right? Do you see feasibility of a for-profit commercial entity operating as a PPSA? One, again, as usual, what do you believe will be the benefits? What things do we need to be careful about where the transition from a not-for-profit to for-profit may not be that seamless? Thanks.
Yeah, so I mean, my simple answer is yes, that we heard about examples of efficiency being mentioned. We heard about examples of scale being mentioned. We heard about examples of digital bringing in as to augment the efficiency further. I think these are, and also, I mean, if you look at PPSA, there is a complex process. We can actually kind of divide that process into provider engagement, then logistics management, which is actually diagnostics and drugs delivery, and then the patient engagement part. To add, to kind of complement to your second question, so probably the piece which is lacking is the patient management side, which is, I mean, from the perspective of actually counseling, supporting patient adherence support system, and from the management perspective of drug delivery, and then making them kind of ensuring them to adhere to it, digital and also play a role. So in summary, I would say this is and also the other part is that the capital for actually getting into this place. So currently, these NGOs in the field are also struggling. So when Pidambar mentioned about that EMD money, then probably in the process of actually kind of running at PPSA, also the one is that when they accrue the amount they would want to kind of sufficiently run because of the performance base. The performance will take a time to reach to an optimal level. That won't come in the first quarter. So that there is a capital cushioning needed for actually functioning. That probably the private players would have that capital to kind of cushion and then run seamless operations. So they have demonstrated efficiency in running complex operations. We could leverage for it, and probably complement with the patient support system management with a hybrid model. That's why my thought process is. Thank you.
Thank you, Shibu. So again, economies of scale or efficiency, coordination across different units, and use of digital technologies may be areas where private players or for-profit entities may have an advantage. Yes, Shibu.
Just one more point. So we have been doing this PPSA in a set pattern. We don't know, there might be a different pattern altogether. So that private players could bring in that perspective into that. Thank you.
Got it. So it's just sort of operating model innovation or business model innovation, as we say in our business school parlance, maybe. Arnab, if I can come to you now, because one of the points that Shibu mentioned was this patient engagement, patient-facing activities. He cited as maybe one of the difficult tasks for private players, because this is not something that they may be doing usually. They may be doing lab processes. But we heard from Manisha earlier, and you have been engaged with 1mg, where 1mg has provided these patient-facing services. Could you talk about the nature of this partnership from your perspective? And I think you played the role of PPSA, correct? And then you outsourced a part of your service portfolio to a private player. What has been that experience, and how did 1mg, in your understanding, develop these capabilities to be patient-facing? And do you expect this to be replicable elsewhere? Thank you.
Sure. Thanks, Arang. So I think our model was in some ways like a consortium. CHAI played the role of provider engagement and demand generation, whereas I think 1mg came in and provided the service delivery, the logistics support, the patient engagement piece. So even, I think, just building on Shibu's point, even on the patient engagement piece, I think there are private sector organizations which can do it. I think 1mg obviously demonstrated that during our pilot project. They managed the counseling, they did the follow-ups, adherence tracking. I think all those things they kind of managed fairly well. There are other organizations like, Portia, Healthcare at Home, who provide similar services, again, in the private sector. So I think there is a fairly strong ecosystem and growing ecosystem of organizations which can do parts of it or the whole pieces, whole thing end to end. One, again, I think if you look at it, PPSA again is a complex model. There is the demand generation and service delivery piece. Demand generation inherently is more challenging because you don't have a control on how many notifications you will get, which providers will engage. There's a sales aspect to it in some ways. And that kind of acts as a big unknown. I mean, if you're kind of trying to cost out a model, if you're trying to figure out your staffing, costing, and all that thing, I think that's where there's a lot of unknowns. The service delivery is fairly straightforward. I mean, you can say that, okay, I'll pay or I expect 100 lab tests and I'll pay you X amount of rupees, or I'll do so many drug deliveries, I'll pay you Y amount of rupees. So I think, going forward for PPSAs also, I think that's something which we need to figure out. I think maybe private sector organizations generally are more service delivery oriented rather than demand generation oriented. I think some of them would have to kind of backward integrate to kind of also build those capabilities of, let's say, provide engagement to actually do an efficient job end to end.
Thanks, Arnav. That's an excellent point. One of the issues or difficulties with thinking of for-profit organizations is there's just a whole gamut, right? I mean, a pharmaceutical company is a for-profit entity, which maybe has strong capabilities to deploy a field force and generate demand for their products. Can they do that to generate demand for TB services, right? That's unclear. And then on the other hand, you have labs, but I think also a growing ecosystem of startups. I mean, maybe 5 years ago, we wouldn't have thought about Portia or 1mg for that matter. So maybe we should not look at conventional places when we say private sector. Maybe people will come out of the woodwork and say, hey, this looks like an interesting opportunity. I can create a startup which will have a collection of these capabilities, possibly, right? And so maybe one of the things I'm taking away is we need to reach out to different groups of private players, different ecosystems. But this is a start. This conversation is a start, but there may be other forums where we may want to go. Thank you for that thought. Ria, I'll come to you now. And I think what I want to hear from you is you and I'm sure the group that you represent, the most important group, patients, TB survivors, have experienced services, sometimes from the program, sometimes from public sector, sometimes from private sector. When you hear this conversation about engaging for-profit commercial entities, what's the first sort of gut reaction thought that comes to your mind and say, wow, this is exciting, this is what we've been waiting for all the time, or oh no, this is the last thing that we want? I don't know. So maybe that first gut reaction. And second is what are the things that may be needed for it to work for the patient? So maybe two-part question. Thanks.
Thanks, Sarang. And in response to your question, I'm going to pose another question to the audience. Okay, and the question is, I'm sure many of you have renewed your passports in the past couple of years, or had a new passport done. What has it been that you liked about that process? I want you to put in the words in the chat, and I will get to that at the end of my comment. So if you could just please let me know what you liked about the process, that would be really great. So now back to your question, Sarang. I think it's important to identify what problem are we trying to solve, right? And the first thing is when Dr. Vijayashree gave her presentation, I realized that, I'm one of those statistics that she mentioned, with over 70% of people accessing care in the private sector. I was one of those people. And much to my surprise, and as a person, I mean, just imagine yourself as if you've just been diagnosed with TB. You have no idea about what's going on in the public sector, what's going on in the private sector. And for any layman, really, I mean, I was mentioning it to someone the other day, but I know a doctor who's an MD who doesn't know that we have a national TB program with TB. So the whole conversation about public and private sector really doesn't matter to a person who's affected by TB. We just want the best services that is there out there, right? And in terms of in terms of service, and I think I'm just going back a little bit to my own experience, right? So I went to the private sector. It started with an ache on my foot, my experience with TB, okay? And so TB doesn't have to be in the lungs as it can be in any part of your body. And I had a surgery, and I remember my doctor, he tore my tissue into half, and he sent it to 2 labs. He sent it one to a private lab and one to the in-house lab. You know, the private lab report was very efficient. It came out very quickly, and it said that I had no TB. I just had a regular infection. And so I started taking regular meds, antibiotics, you know, not TB medicines. And the in-house hospital report, which was actually positive for TB, got lost in the whole bureaucracy of the hospital system. And so I actually didn't know I had TB for the first 6 weeks. Until I woke up one day and I realized, as a person who's affected, that, hey, I never saw that second report, you know. And so that speaks volumes in terms of inefficiency of services within hospitals, within just by sheer population numbers in India. And I feel like there are 2 points that I take away from here, since we spoke about diagnostics, and many speakers touched upon this. It's not just about you know, getting the test done. It's about doing the test right, you know, and a lot of people, even private players, aren't following. I mean, my private test result came out negative for TB, right? And that, I mean, there could be many reasons for that, but you know, I would expect a standard of care. I mean, whether I go to a government hospital or a private hospital, I would expect a high standard of care in either places, right? And that's something that I just wanted to convey. And the thing is, as a person affected, I took the wrong meds for six weeks. I run the risk of getting drug resistant. Again, you know, the inefficiencies of the system. At the end of the day, and this is a really interesting point, the person who cured me, and I was one of those other statistics that jumped in and saw dozens of doctors because of the low quality of care, and every doctor giving a different opinion on what's going on. Ultimately, it was a government hospital doctor in his private practice, who I went to meet him at 9 o'clock in the night, who ultimately cured me, right? And it wasn't the specialist in the private hospital. It was because they all messed up. They gave me the wrong meds. They gave me the wrong dosage of meds. It was a hellish experience. So what I'm trying to say is, it's such a huge problem, right? And it's complex in so many ways, and that we really need the efficiency that the private sector can give in order to get. And I liked what one of the earlier speakers had said, Dr. Venkat, where he mentioned that, you know, the private sector looks at results and not so much of process. And I think that is so important, because that's what we want. We want results. At the end of the day, we want to end TB by 2025. Right? And that's really, really important. The second point I wanted to talk about is in terms of potential of the private sector. So, you know, in India, because again of sheer numbers, I mean, I currently live in Denmark. I live in a developed country, and I know, like, when I meet a doctor, he has time to explain to me what I need to eat, what I don't need to eat. But in India, I never had beyond this 2-3 minutes of meeting the doctor and moving on, right? And I had so many questions, and so many people with TB constantly come and ask me, what do I eat? What do I need? I mean, they have counseling requirements. There's so many requirements for a person, right? And we need a provider that actually, and I like the idea of the patient provider support agency that was raised. I think that's really important, because the nurse in the hospital is overworked, so is the doctor, and we really need someone to take on these services to be able to deliver. And I'm just going to just in the interest of time, and I just wanted to hear everyone else speak. I think I'm just going to hear the comments of what people said, okay, with the passport, right? And as some of you may be aware, a private player, I think it was TCS, that's taken over passport services in India, right? And you would see, like, the comments. There was ease of service, there was rapidity, there was seamless service, there was professionalism. People view you as, you know, important, as not as like a burden on your head. It was convenient, it was stress-free, it was easy appointments to meet the doctor, it was smooth communication. Believe me, all this is not there in TB. You know, patients are desperate, running helter to skelter, trying to figure out a way of just getting better. And that's what we need in TB. and I feel like if there is any example of showing a scenario where the private sector has come in and totally revamped a process to make it efficient, it is for me personally too. It was I renewed my passport 15 years ago, and I renewed it recently. I knew the difference, and so we need to look at this and reimagine private sector engagement and service delivery in a completely different light. Thank you.
Thank you, Ria, and a lot of very valid points. I didn't want to reveal my age, but I was also going to say that I first, got a passport done when there was only one passport office in the entire city, and you had to stand outside the gate at 6 a.m. We've come a long way since then. Yeah, I mean, of course, these analogies are useful, and at the same time, we understand the limitations. TB care is, I mean, you are the best person to sort of know this, that TB care is far more complex than passport delivery, but there are lessons to be taken. The spirit of, seamless delivery end to end, where the patient or the customer doesn't need to know who is doing what, because they only care about what's the value delivered. How can we bring that discipline into TB care? The other point that you made, and I think it gets lost sometimes when all of us speak to each other who've been in this sector for a long time, is one of the most important private players who is already providing services is the doctor, right? I mean, so they are already engaged, but there are challenges. And so when we now think about engagement of commercial entities, they are in some sense an additional layer. We don't like to say that, but they're an additional layer to ensure that these spokes, individual doctors, individual providers do end up providing high quality care, and not, patients don't have to suffer like you did some years ago. Again, I think to sort of bring everything together, I'm keeping track of time as well. We see that there are potential benefits of engaging private players. Some of those ways in which you can engage with private players or for-profit players are the conventional ones, but there may also be unconventional roles that they can play. The question is, for those unconventional roles, do they have the capabilities even in their business as usual? It may not be obvious that they can do demand generation, for example, because it may not be what they do in their business. Counseling, for example, private hospitals, private doctors may be as bad or good at counseling. It may be as non-existent as in government hospitals and clinics. So, which means they may also have to develop new set of capabilities. I want to go back maybe to Shibu and Arnab and ask them very point blank question. And I think a question was raised already. So for the benefit of everyone, I'm sort of repeating it. Can I make money as a private for-profit commercial entity? Is this sort of, because I have to report to my shareholders or anyone who's invested in me, you are telling me that, oh, all these things are great and there's an opportunity. Can a private player make money out of all this? Shibu, do you want to start off?
I think that's where they mean their capabilities, they probably will think in different way. So they probably will reach out to multiple disease programs and bundle all the services and then package it in there as a bucket of services rather than one TB services. So they have a bigger market and then they kind of monetize from that. That would be my thought process. Probably they would want to monetize. I don't think that any private player will come for a service delivery. I mean, from a service perspective without making any profit. So that we don't know at this moment how they're going to do it. That is something which we expect they probably will do differently to monetize it. Thank you.
Thanks, Shibu. Before I go to Arnab, I want to also, if it's okay, I want to reach back to one of the speakers who represent the private sector and have engaged with different programs. Dr. Nilesh or Manisha, if you want to respond, if you're still around, if you want to respond to this from a commercial point of view, how do you look back on that partnership? That was good business, or okay, we did it, but didn't add too much to the bottom line?
If you ask me specifically for NACO, in fact, I can relate to most of the PPPs. They come with a lot of volume. So commercial viability, actually volume drives. I am not referring to a lot of PPPs where they do not even clarify what kind of volumes are going to come, what is going to be test mix, all that I'm not talking about. But wherever there is a clarity, like I'm sure TB, whatever work we have done as of now or for NACO, there has been a clarity, and hence commercial viability was very well thought while bidding. So I'm not worried too much on commercial viability. If all the norms, as I said, who are the bidder, the qualification criteria and everything is well set, I think there'll be healthy competition, which is must.
Thank you, Dr. Nilesh. I think Manisha probably is, I don't see her. Maybe she had to log off. Dr. Sajdeva has joined. Dr. Sajdeva, I will, come back to you. Just give me a second. I want to also hear Arnab's thoughts on commercial viability from a for-profit entity perspective. Arnab?
I think I would echo what Shibu and Nilesh, Dr. Nilesh said. I think, for these contracts, commercial organizations will obviously think of profits before bidding. But to just give an example, like, let's talk about gene expert testing. We know that in the private sector, there's around 50% utilization of these machines. So for a commercial lab to bid for, let's say, expert testing from public sector, the incremental cost is very minimal. I mean, they can just perhaps deploy their unutilized capacity, maybe hire an additional person, run extra shifts. So the incremental cost in that sense is fairly low. And, I guess hence it definitely makes sense for them to bid for these things.
Thanks, Arnab. So I think what I'm hearing is be also sort of creative in thinking about your cost. If you do everything on the basis of average cost, you may be actually losing opportunity. Marginal cost, incremental cost may be a way to go. Thanks. Dr. Sajdeva, I'll come to you. You've been in this space for so long. Not only that, I think when you were at NACO, you kind of spearheaded private sector engagement there. In TP you did, now you wear a different hat at the union. What we are hearing is two sides of the story, where on one end, we believe that private sector can do a lot. They have a lot to contribute. They have capabilities. But we are hearing murmurs from the other side, from the private player side. We need clarity. We need the rules to be very, straightforward. There's a lot of friction in making things happen. Would you want to say something that will, I don't know, give some confidence, assure private players that, there is a way, that some of these issues have been thought through? Of course, there's always more ground to cover. So over to you.
Thank you, Sarang. I think some of it that there is some friction, there's no level playing field I mean, we all know that feeling is there with most partners, and we have learned through this process how to sort of work around those feelings and how to make them a part of the programs. So if you recall, within the TB space, the first NGOPP guidelines, we call it non-governmental organization private provider guidelines, had only a space for private providers to do what we wanted them to do and refer patients to the public sector. We started with that. And then they saw two revisions where they said, okay, keep patients with yourself or take some schemes. And as we learned through the process of implementation and observing that these are not working well, is when we first started engaging with the large non-governmental organization and private sector through global fund projects. So we were the first one to introduce private sector. Indian Medical Association was involved in the global fund project. Initially, the Catholic Bishop Conference of India, they were involved. I mean, they didn't believe that they can be part of 2007. When we were saying we will get you on the program and you will be able to implement programs, they did not believe that they can actually get funds from the government and they can work with the program. So we have come from that stage, and now there are demands. And the last straw was when we said initially all the proposals were only non-governmental organizations were eligible. We said even for-profit organizations are also eligible to bid or apply for government funding. I mean, initially they never they saw for-profit with a different lens, and then we said, okay, for-profit organizations are also eligible for bidding. So many for-profit organizations started applying and getting funds for public health. I mean, not as vendors of say gene expert or drugs, etc., but as implementers of a national program. So that was again a huge change in the mindset. And now with the latest partnership guidelines, where we said it's an outcome based support, and where both for profit and not for profit, they compete against each other. And we've also learned sometimes that for profit are probably more efficient in certain areas and certain interventions, as you were already saying, that they don't, Anna was referring, they don't work from ground zero. They have something on which they built on. So there are economies of scale with for profit. So I just want to convey that you see this change in the program. I hope more and more programs beyond TB care. We introduced that in NACO also. So we had a huge, large lab network supporting in viral load testing. First time in NACO that some private partners was engaged in a viral load testing, and they are still continuing. I mean, so, and the uptake has been quite good and very well received. Both, even in procurement at NACO, procurement has always been a government function. I mean, but not without naming, but we had also outsourced procurement to a private organization at that point of time. I'll conclude here, but open to questions and further clarifications.
Thank you, Dr. Sachdeva, because I think sometimes in the moment we lose track of how much progress has happened. So, you recounting the historical development of some of these ideas was helpful. The main sort of transition has been from procuring individual services. So you talked about someone being a vendor to being a partner. I think that's a major transition.
Yeah.
Where we're talking about now complex services, program management itself being done by private players and not just conducting one individual test. That's very helpful. I'm mindful of time, and so I want to hand over to Dr. Shri. I think this has been a wonderful discussion. Of course, it is impossible to conclude and come back with, okay, here are ABC things and everything will be okay from tomorrow. But we hope that this is a start of a dialogue, that if there are private players, private entities listening to this conversation on whatever forum they are now, that they start thinking about, okay, maybe this is a viable business opportunity. And that on the other end, there are well-meaning players who want to, engage in earnest so that the final service provided to the patients is better. And patients do get, well. I think there will be follow-ups. I'm sure everyone on this group will look for more opportunities to talk to those private players. Let's call them prospects, and share more information, so that the thought process is aligned. So I would take this not as the end, but the beginning of the conversation. And Dr. Shri, over to you. Thank you.
Thank you so much, Sarang. It was such a rich information. Thank you everybody, the panelists and the speakers. Professor Venkat, may I request you to make a concluding remarks before we close the session? Over to you, Professor Venkat.
Thank you, Sri. And I wasn't prepared for that, but then I will take this responsibility. I think the essence of what we are attempting is very well narrated by Ria. She said that, we should be reinventing the way that services need to be delivered from the patient centricity point of view. If you keep that in the mind, it hardly matters whether the person is seeking from the public sector or the private sector, as long as there is some kind of confidence that he or she will get the services without any kind of hitch or any kind of irrationality or any kind of financial hardship. So that's the essence of any partnership that may be the guiding principle. I think all the speakers and the panelists have been wonderful in creating a new set of thoughts. Shibu's point about the private sector can reinvent maybe the PPSA is not the only model that they can, we need to stick with. Maybe they will come and improvise, which will allow the program to also learn from those initiatives or innovations. And these are some of the things that we need to continue to, converse or continue to have a dialogue about, so that we are in a position to reach the goal that the NTP is setting up itself. Thank you, all of you. And it's been a pleasure to have each one of you and listen to each one of you. Thank you.
Thank you, Professor Venkat. Before we finish, there will be a survey poll which will be popping up. I request all of you to respond to that poll. And we look forward to keep in touch. This is just a beginning, and we hope to have this dialogue continued. Thank you, everyone.